What you write, your name, you write.
Good afternoon to everyone present here with us today. This is Shriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Ved Chaturvedi. Sir is MBBS, MD, DM Senior Consultant at Sir Ganga Ram Hospital, Vice President of Asia Pacific Rheumatology League, APLAR. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is enlarged kidney uh, enigma, cracking the case of chronic renal failure. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
Thanks. Thank you so much. Am I audible? This is, of course, about me, which I have been introduced, but I just want to highlight that we were the first one in the country to do the ultrasound, because this is there in this case since 2003. We are doing ultrasound, that is a rheumatology ultrasound. We were the first one to start in the country. So since 2003, we are doing ultrasound of the joints and the salivary gland. So this is number one. And what is APLAR? What she was telling, it is a Asia Pacific League of Rheumatology. It is an organization of 30 countries. So I was vice president. Now I am the deputy general secretary, and I did my DM from SGPJ Lucknow, and I was in the first batch of rheumatology and immunology. So that is the and earlier I was working in army hospital. That's why this rank of lieutenant general. So I retired as a lieutenant general. I was a rheumatology head at army hospital. My brief is to present a case today. Normally, case presentation generally is done by juniors, but I decided to have this series of case presentation. Is very important because probably not only Indians, everybody learns from a story, and each case is a story actually. So, like you remember, good or bad, from stories in our when we were child, we were told that there was somebody who was a bad and he was punished by God. So you remember. So I always feel that the medicine is learned by case presentation. So I am presenting a case of a middle-aged female. So you can imagine a middle-aged female walking in your OPD, and she didn't have any other problem in the past. She was a resident of Delhi and basically a homemaker, and she presented with fever, prolonged fever for 1 month, and not associated with chills or rigors. So basically, fever. She also had bilateral parotid swelling and some dryness of mouth and mild abdominal discomfort, generalized discomfort. And there was no history of shortness of breath, or a cough, or a palpitation, or a loose stool, or burning micturition, or increased frequency of micturition. So she didn't have any, and there was no other features suggestive of connective tissue disease. So for this audience, everybody should know how to take a history of connective tissue. So connective tissue diseases. Now connective tissue, where is the connective tissue? Heart, everybody knows heart is here. Eyes are here. Eye diseases, heart disease, lung diseases. Where is the connective tissue? The connective tissue is ubiquitous. It is present from here to the toe. Collagen. Hair is made of collagen. Your mucosa mouth is made of collagen. Your skin is made of collagen. Eye has a collagen. Lung has a collagen. Heart has a collagen. So you have to ask a detailed history starting from hair loss, eye redness, any stuffy nose, mouth ulcer, ear problem, any problem in the lungs. interstitial lung disease, pericarditis, pleural effusion, ascites. So this is how we take the history of connective tissue disorders. So you must remember that how you start from head to toe. In fact, I call it head to toe survey. So that is the best way to take the history of connective tissue disorders. Prior to presentation to our hospital, I am working in Gangaram Hospital. She was treated with a urinary tract infection. Now, why urinary tract infection? Somebody comes with fever, and somebody is having fever since long, and some urine examination shows some little protein here and there. So a treating doctor, rightly so, a primary care doctor, he will think it is UTI, and she was given some treatment for UTI with resolution of symptoms for a few days, followed by recurrence of symptoms. Again, fever came. So, personal history, normal. Family history, normal. Obstetric history, basically uh, nothing important. No history of miscarriage or pregnancy related complications, so no issue. Examination, there was no evidence of pallor or icterus or cyanosis, clubbing, pedal edema, or lymphadenopathy. That is how we do a normal general examination. Respiratory system was normal. Cardiovascular system is normal. Abdomen was soft, non tender, and CNS examination was normal. So, virtually normal, except mild swelling of the parotid. Uh, Hemoglobin was 10.1. TLC was normal. DLC was also normal. Platelet was also okay. ESR was 15. And uh, if you ask me anything very important, by and large, uh, they were normal, except let's come here. Albumin was 2.9, and the creatinine was raised 1.41. And this is the other investigations. Sodium potassium, I'm also finding difficulty in reading because of some. Uh, I got recently eye operation, so I don't have those glasses, reading glasses. So uh, I'm finding little difficulty in reading. Please pardon me for if, but I remember this case because I had dealt with it. But I just wanted to that whenever there's a creatinine is high, somebody has a, so ANA was negative, so probably we do an ANA, so we always feel that it could be a renal disease because of, so ANA was negative, so it's not lupus. So that is number one. And myeloma panel was done, probably if I remember correctly, protein was high, so the myeloma panel was also negative. And then the serum IgG was high. Serum IgG4 was 239, and peripheral smear was not very conclusive except microcytic hypochromic anemia. And the absolute reticulocyte count was okay. Ultrasound, because patient had gone to the nephrology department. Now, why nephrology, you will ask me? Because earlier somebody has diagnosed UTI and he referred to the nephrologist because he's running temperature and the UTI is in control, and now he's again having fever. So they do ultrasound of the KUB, which showed a bulky kidney. Now, large kidney, no, normally we expect in, we call it chronic kidney disease, CKD. Now, what is CKD? It's a bilateral small kidney. So that is how most of the reports you must have seen: bilateral small kidney, where cortex and medulla cannot be differentiated. So that is how the chronic kidney disease present. But if suddenly somebody says bilateral bulky edematous kidney, so kidney, large size kidney, so what can be the, what comes in your mind? Probably what comes in my mind is probably something is deposited in the kidney. And vaguely I read somewhere in my college days, but these probably one of the lymphomas, probably Hodgkin's or non-Hodgkin's, they can cause large kidney. So when this case came to me, that yes, is a large kidney. So I said, is large kidney, could be Hodgkin's, non-Hodgkin's. Something came into my mind, or maybe some deposition disease. Uh, we examine, and it is generalized lymphadenopathy, axillary, mediastinal, retroperitoneal, inguinal. So we were more suspicious as probably it's a more lymphoma. Some hypodense liver lesion was there, bulky kidney, perinephric and tissue. This was possible lymphoma. So we always thought it is lymphoma, especially after the ultrasound. Now, I don't know why my boss sent to me, probably because of parotid, and he's a nephrologist. And I am doing nowadays a lot of ultrasound of the salivary gland. So these are the salivary gland. And I did the ultrasound of the parotid and submandibular and submental. Parotid is easy to do. You just put your probe here, like something like this and something like this. Normally, it is seen like this. Now, what is a normal appearance? It is homogeneous and it is hypoechoic. Now, for those who are not familiar with these terms, homogeneous, so everybody knows it is something like ground glass. Homogeneous. It's not homogeneous. This is homogeneous. So homogeneous and hypoechoic means echoes, returning echoes are less, so they are little white. So it is not black. Black means no echo. So it is normal appearance of parotid is this, that it is a homogeneous and it is a hypoechoic. As we learn gradually that sometime you can see this picture, it becomes little non-homogeneous, and some areas of the hypoechoic, see black. If you as a clinician, you may say that some areas are black, some areas are white, and gradually these black areas keeps increasing, so they become more non-homogeneous. And if you put a doppler, you can see sometime a doppler signal, and sometime it becomes like this, like a fibrosis. So it is like grade 1 changes, grade 2 changes, and grade 3 changes. So basically the changes of in homogeneity and your ecogenicity become gradually less, and I call it like a honeycomb. So like honeycomb appearance, and this is the thing which we call it primary Sjogren syndrome. So that is how my boss sent to me, that is it a primary Sjogren syndrome or something which involves the kidney also. So you have a bilateral parotid swelling, and when I did the ultrasound, I'll show the picture. What was the picture of this ultrasound? I always thought it is a Sjogren syndrome. So I did an ultrasound. Normal ultrasound is this. We were expecting something like this. Why we were expecting? Because patient was running temperature for many months, and patient had bilateral parotid swelling and some kidney disease. And kidneys, though were bulky, the bulky kidneys are not known in Sjogren syndrome. But we thought maybe something which we may not have seen. But we saw this picture. Now, this picture I have never seen, frankly speaking. I didn't know what it is. I told it's not Sjogren syndrome. It is something different. Maybe lymphoma, which I am not great about diagnosing lymphoma until I do a biopsy. But it's not even lymphoma. something very different, something which has a sheets of the hypoechoic areas with total non-homogeneous and some Doppler signals and some fibrosis. I knew the report of the bulky kidney, so I thought, is it lymphoma or is it a IgG4 disease? So it came in my mind. Probably it may be a IgG4 disease. Just a minute. Hello. Can you just give me my? There's some call from emergency. Just a minute. Sorry, there was a call from emergency. So this was the picture, and this is a very unusual picture. In last so many years of my experience, I've never seen a parotid gland like this. So my diagnosis was either it is a lymphoma or a IgG4 disease. So let's see what happens then. Of course, the gold standard is biopsy. So the parotid biopsy was done, and parotid biopsy shows lymphoplasmacytoid infiltrate in the focal areas of salivary gland. Don't get scared of these words. So lymphocyte, you know the cells are, you have neutrophils and lymphocytes, and lymphocytes are T cell and B cell, and B cell becomes plasma cells. So there are a lot of lymphocytes and plasma cells. So that is that is what we see in the focal areas of salivary gland, with the some atrophy of the acinar atrophy, with mild interstitial fibrosis also, and remaining salivary glands is unremarkable. And when they did the immunohistochemistry, and what is immunohistochemistry? Basically, to see the what are the markers sitting on the cell. Earlier, we used to recognize cells by neutrophils has multiple lobes, while lymphocyte is round. Now, all cells are recognized by the markers sitting on the cell, like famous markers are CD4, CD8, which we read in the HIV. CD4 is helper cell. Now these are markers. They are called CD. CD stands for cluster differential. So in this, the marker is, when they did the immunohistochemistry, they found abundant plasma cells, positive IgG4, about 150 per high profile. So more than 50 is significant. It's 150. So definitely IgG4 disease, and even ratio is very high. So diagnosis IgG4 related disease, which we were suspecting, and kidney biopsy also is suggestive of IgG4 is positive in 40%. Diagnosis basically chronic interstitial nephritis with the IgG4 related renal disease. So tubules shows moderate tubular atrophy, and the blood vessels no vasculitis, and basically are there is sclerosis but no inflammation. But basic finding is these positive in the basically moderate plasma cell rich infiltrate. So in IgG4, what happens? There's an infiltration. And what is the infiltration? By lymphocyte and plasma cell. And plasma cells are abundant, And when you stain these plasma cells, they are IgG4 positive plasma cells. So IgG4 positive, that's why the disease is called as IgG4 disease. Final diagnosis: IgG4 related disease with the parotid gland involvement and kidney involvement. So the IgG4 disease was not there when we were in medical college. In fact, when I did my DM also, they were not there. It was described in 2001 by a Japanese physician. 2001 is fairly recently, hardly 20 years back, 23 years back. So if you don't know about this disease, don't feel bad. So many other physicians are also learning about this. The disease is infiltration of the plasma cell, which are IgG4 positive in many tissue. The most common tissues are salivary gland. So this uh, patient had infiltration in the salivary gland. And the next common organ which is involved is actually pancreas. In this, it was kidney. So that's why it makes it rare that kidney we have not seen. We have seen many organs involvement. We have seen parotid, we have seen lymph nodes, we have seen intestine, but we have not seen kidney, and kidney were large. So that was a suspicion. So not only parotid were large, even kidneys were large. Pancreas was normal. So that's an unusual case, and it is confirmed IgG4 is level is also high in the blood, and the kidney biopsy and this biopsy also both shows the IgG4 related disease. Treatment is simple. It is treated by steroid. So you give steroid about 1 milligram per kg of body weight. You can give the even higher dose in the beginning. So it was treated by salumedrol for 3 days. That is the, and then 1 milligram. You can always there are, today I had a case of IgG4 disease who had a paravertebral mass. So there was an infiltration of lymphocyte, and the differential diagnosis of swelling can be anything. So there was a paravertebral mass which was diagnosed as tuberculosis. Patient was on ATT, but the biopsy shows IgG4, and patient was diabetic, so the steroid could not be given. So when steroid is not given, then you can give other drugs like methotrexate, MMF, other immune modulators. Like even steroid is an immune modulator. So that is how it goes. So you can give these this. And what is IgG4 related disease? It is called IgG4-RD. RD is nothing, related disease. So try to use the correct word. It is called IgG4 related disease. Now, what is IgG? Immunoglobulin G. Now, immunoglobulin G has four subtype: G1, G2, so G4. So IgG4 related disease, it's a multi-system disease. Why it is multi-system? Because this infiltration of lymphocyte and plasma cell in multiple organs. So they are multi, and these infiltration, these plasma cells are rich in IgG4 plasma cells, and there's a fibrosis also. And this fibrosis is typically called as storiform fibrosis. Storiform means something compressive fibrosis, compression of the organ, and elevated IgG4. And of course, when there is infiltration, you will have a organomegaly and mass forming lesions. It mimics malignancy. So simple to remember: if there is some swelling anywhere, what comes in your mind? Tell me. If suppose I have a swelling here, you may see, sir, this is a lipoma, lymphoma. So you must remember, try to learn that it can be a IgG4 infiltration also. So IgG4 disease commonly involves the salivary gland, pancreas, and retroperitoneal structure, and kidney also. So kidney also it is can be involved. So these are the structures which anywhere it can be involved. Normally, what will happen? You will see a person who has a swelling in the lids. So eye swelling. So basically, you must remember. So they will present like this. Eye, they will present as a lacrimal gland swelling. They can present as thyroid gland swelling. They can present as a nodule in the lungs or masses in the lung, and they can present the kidney, which I told you. They can present as aorta swelling, which you will there's a fibrosis around aorta, and of course they can present as a diffuse swelling of the pancreas, diabetes, and they can also present as a basically salivary gland, other salivary gland, major salivary gland. Any part can be involved, but generally, whatever cases we have seen in Gangaram, they'll present basically either the salivary gland or the neck swelling, eye swelling. Maximum comes to the eye department. So, eye department, some swelling, biopsy should be done and sent to a person who knows to read about IgG4. Sometimes people can't read it because they will only write there's no evidence of tuberculosis. No, so that probably it requires more little more of a experience. So this is how the IgG4. So key learning points are IgG4 related disease mimics malignancy naturally. Any swelling will mimic malignancy. So suddenly you see a CT and pancreas is enlarged. You always see it could be malignancy. In kidney is enlarged, you will always see it's a malignancy. Some swelling in the eye, you can see always malignancy. So any differential diagnosis swelling, IgG4 related disease should come, must biopsy and do the blood level of IgG4. So that is how biopsy and IgG4 staining are essential for diagnosis. So only not do the biopsy only. You write to the pathology, please do the staining for IgG4, and steroid remains the first line of treatment. So nothing great about treating that diseases. They are very simple to treat but difficult to diagnose. Sometimes they can present as a intestinal obstructions also. So conclude, a rare case of IgG4 with multi-system, multi-organ involvement like salivary gland, kidney, and other lymph nodes. They mimic lymphoma. I thought lymphoma with significant lymphadenopathy. I did an ultrasound of the parotid and could come to conclusion probably this is something different. It is not Sjogren syndrome. A early diagnosis is crucial to avoid unnecessary interventions. Unnecessary intervention means so many things. So basically, if you diagnose early, so the plight of the patient is also. So that is how I finished. Any question from your side, please let me know. Thank you so much. Thanks.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Yeah, yeah.
So, sir, the first question is, what are the key radiological findings that differentiate chronic kidney disease from acute kidney injury with enlarged kidneys?
Oh, I'm not a nephrologist. Sorry for. I know I'm a rheumatologist. I only know a little bit about nephrology. What I know nephrology is that there's a kidney, there's a tubules, there is a there are glomeruli. What we know about kidneys only we read from the as lupus. That is the inflammation of the, if glomeruli is glomeruli, that can be sometime can be severe. We call it class 4, as otherwise minimal. So that is how, and sometimes only membranes are involved, called membranous nephropathy. So this much I know. I don't know about, yes, in chronic kidney disease CKD, what we learn over a period of time, that yes, corticomedullary junction, that demarcation gradually fades away and the kidney becomes small. But if the kidney is large, this is a differential diagnosis. Beyond that, probably I can't answer this question. Sorry.
Thank you, sir. There is one last question. And what are the challenges of managing anemia and mineral bone disorder in CKD with enlarged kidneys?
Probably they are more asking about the nephrology question, which I was, because probably people don't know about this is about IgG4. Like if you ask me about the electrolyte balance, mineral balance, and all this, a very complicated topic about the, which probably the nephrologist has to answer. Whatever little I know, that most of the nephrologists, they always feel, which we call it the renal uh, uh, those renal syndromes which causes problem disturbance in the calcium and vitamin D. So most of the nephrologists you must be seeing writing some calcium, some vitamin D. In fact, my brother's thesis was on chronic renal failure and metabolic bone disease. So that's why I learn about little bit about the metabolic bone disease. But more relevant question, probably if people knew about the case, is that how to diagnose a how important is the ultrasound of the salivary gland in the hands of clinician. Look, ultrasound is done by radiologists, they are good in the diagnosis of, but a clinician, to diagnose this is very very easy. You have to just put the probe here and keep putting every day. You will learn normal, which I told you how the normal, how the normal looks like. The uh, and the abnormal, I think those slides are there still. Are they there? uh, if I show
Yes,
you
sir.
those, that ultrasound slides I am searching, I can't see that. It's not going back, I think. uh, uh, can you help? No.
Sure, sir. Let me just check. Let me just check.
Just go from the just go on the first slide.
This one?
Yeah, this one. So
Yeah.
this is, if you keep putting your probe on the uh, parotid, you will see this normally like this. So normal ultrasound is very easy. It's like liver, sheets, sheets, and it is homogeneous. I'm in a meeting. I'll be free after 10 minutes. मैं 10 मिनट, I'll be free after 10 minutes. No, no, no. What message I want to convey, that if somebody wants to learn ultrasound of the parotid, he can see this, every, what how I did. I learned myself this. I did every parotid I put here, and gradually I realized this is normal, and gradually I realized this is abnormal. So this you have to learn. And we always thought Sugran, Sugran, Sugran. In fact, the nephrologist also sent me this case. I'm a rheumatologist. He knew that I do this ultrasound, and he thought probably it's a Sugran syndrome. And I also thought it is Sugran syndrome, this patient. But I didn't find this picture. I found this picture. Now, this picture was not Sugran syndrome, but I didn't know what it is. I knew this is not Sugran syndrome because Sugran syndrome picture looks like this. So when the picture is like this and the kidney was large, I thought it is lymphoma and maybe IgG4. IgG4 comes in my mind because Gangaram has lot of IgG4 disease cases, especially in the eye department. And I learned about IgG4, so I wrote two diagnoses. I wrote lymphoma and I wrote IgG4. And then biopsy was done. It was rich lymphocytic infiltration, plasma cell infiltration with IgG4. So that is the message with this is that if you have a, even chronic, even if you feel it's a kidney failure, or you always feel it is a acute kidney injury or chronic kidney, it has to be chronic, 1 month running, one month. But chronic kidney disease does not mean a CKD. Chronic kidney disease could be something different, like this case. Now, this case is a infiltration of plasma cell and lymphocyte into the kidney, and that is causing the kidney failure because of the sclerosis of the globuli. It is not other like hypertension, diabetes, which causes kidney disease. Thank you so much. Thanks.
Thank you so much, sir. Before concluding, sir, any take home message?
The take home message is that if you don't understand, you must refer to the person whom you feel probably it may be helpful. That is what the medicine has become. No alone person can sort resolve the issue. Sometimes somebody has a fever for 1 month and enlarge this thing, and it is not putting, you can't put 2 plus 2, then refer to a person who can do that. That is the message. And IgG4 disease, all of us has to read today so that you know how it is. Basically, it's a disease where there is an infiltration of lymphocyte and plasma cell in different organs, and the most common organ involved is salivary gland, pancreas, liver, kidney, and around aorta. So that is the message, that IgG4 is a disease new in origin from 2001. And as a physician in any specialty, whether you are eye specialist, you are a this specialist, you are dead, you have to learn this disease, IgG4 disease. Thank you.
Thank you so much, sir, for joining us today, and thank you for answering all our questions. It's our pleasure to have you in our platform. With your permission, I would like to conclude today's session. Thank you so much, sir.
Thank you. Thanks. Thank you.